I'll just wait a minute or two to allow the participants to come in.
All right, Dr. Rios, we are ready when you are. Thank you.
Okay. Okay, well, welcome everyone. This is Dr. Elena Rios from the National Hispanic Medical Association. We are convening our NHMA COVID-19 virtual briefing session number 15. And tonight we are very proud to discuss mental health, addressing burnout in healthcare professionals and family members. We have a distinguished panel. I'll introduce each one at a time. But I wanted to just announce our sponsors and thank our sponsors. That includes AARP and the American Academy of Pediatrics. And we are also very pleased to be an awardee of CDC with our Vaccinate for All program. And you can find out more information about that at our website, which is nhmamd.org. Vincent. So for tonight's session, we are using PowerPoint presentations, and we will have the three speakers with their presentations and then followed by a Q&A. All participant microphones will be muted, but please feel free to use the raised hand feature to be unmuted to ask a question or type your question into the Q&A box for the panelists to address after all the presentations. Please fill out the short post-webinar survey that will be emailed out after the event. Raffle prizes are available upon completion, and recording and slides will be housed on nhmamd.org website and sent out 1 week after the event. We will also have this recording on YouTube. So just a few items about Hispanics and mental health. You know, pre-COVID in 2019, suicide attempts for Hispanics were 30% higher than for non-Hispanic white girls in the high school grades 9 through 12, according to HHS. And according to CDC in 2019, suicide was the second leading cause of death for Hispanics ages 15 to 34. From 2008 to 2018, serious mental illness rose from 4% to 6.4% in the Latinx Hispanic people ages 18 to 25, and from 2.2% to 3.9% in the 26 to 49-year-old age range, again, between 2008 and 2018. Next slide. So also in 2018, in terms of healthcare for mental health, Hispanics were 50% less likely to have received mental health treatment as compared to non-Hispanic whites. And approximately 34% of Hispanic adults with mental illness received treatment each year compared to the United States average of 45%. Only 5% of physicians are Hispanic, and other workforce sees the same trend. Nurses, counselors, and others that are involved with mental health care. Next slide. So one of the important things to realize, and I think COVID has really brought this up to our society, that there's a lot of discrimination in our society, but the experience of discrimination leads to a cascade of stress-related emotional, physiologic, and behavioral changes. It also evokes negative emotional responses such as distress, sadness, and anger. Physiologic changes meant to maintain homeostasis through the stressful event. And often we see an increase in behaviors that harm health, such as drinking alcohol or smoking tobacco or other substance abuse, and a decrease in healthy activities such as sleep and physical activity. So the COVID-19 pandemic has added to all of this stress, given much of the mortality and morbidity that we've seen in our communities with grief, isolation, unemployment, the public charge issue for many of our families that have people waiting with green cards for their citizenship, or people that are undocumented, and the essential and health workers in our communities. Next slide. So for Latinos and COVID-19, we have seen a trend overall, in general, almost 3 times more likely to be hospitalized than the white non-Hispanic persons. And again, 2 times more likely to die from COVID-19 complications. Hispanic adults reported an average stress level of 6 or 6.1 on a scale where 1 means little or no stress, and 10 means a great deal of stress. This was higher than the average levels reported by white or Black adults. And nearly 2 in 3 Blacks and Hispanic adults said they could have used more emotional support than they received since the pandemic started, compared with 55% of white adults. Next slide. I think that's it. Yes. So I just want to comment that this session is really to focus in on what can we do now that we know we have all of these issues in our communities, and what has been done, and what can we do in the future to improve mental health of our communities. So our first speaker to give us some insight is Mr. Corey Feist, who is the president and co-founder of the Dr. Lorna Breen Heroes Foundation. Mr. Feist.
Thank you so much for having me, and thank you for engaging this really important conversation. The Dr. Lorna Breen Heroes Foundation was created in the name of Dr. Lorna Breen. She was a physician who died by suicide April 26, 2020, just 2 years ago, almost to the day that we're giving this talk. In fact, 2 years ago exactly to this day, the New York Times published her cause of death. And that cascaded a response from the healthcare community, which was really the catalyst for this work. So let's go on to the next slide. We created our foundation with the focus on reducing burnout and supporting the well-being of the entire healthcare workforce, envisioning this world where seeking mental health services is viewed as a sign of strength. This is Lorna's story, and you'll see as described by me in this next short video. In Vito, it's not launching, so you might need to, there it is. And we're not getting the audio either.
People don't realize how hard it is to be a healthcare worker. And that is why it's so important for those in the medical community to really pay attention to her story, because she was like many, many of them. Lorna was the aunt to 8 nieces and nephews, and She was a world traveler, and in fact, it was her passion to share the things that she really loved with others. March 10th was the last day I took a picture with her. We were on vacation in Big Sky, Montana, one of our ski trips. And she left just a couple days later to go back to the emergency room and take care of patients. She was a very driven physician. She contracted the virus herself and tried to recover at home. When she didn't have a fever for 24 hours, she called and went back to work. She was scheduled for 10 12-hour shifts in a row, but she wasn't working 12 hours. She was working 15 hours and 18 hours. Patients dying in the waiting room where their portable oxygen would just expire, and not enough beds, not enough help. She called us and said, "This is going to end my career. My colleagues are going to be able to recognize that I can't keep up." And we said, "Then you should go home." But she didn't, because she was a dedicated physician, just like so many healthcare workers. Only a handful of days later, she called Jennifer and was basically in a catatonic state. She couldn't get out of her chair. At that point, we solicited the help of some of her childhood friends and her medical school friends to get her physically out of Manhattan. Lorna was in really rough shape, so Jennifer, she drove her big sister to the hospital, like you do. Lorna spent about 10 days in the hospital, her first ever mental health treatment. And only a day or two into that mental health treatment, she started to call home and say, "Now that I've gotten help, it's gonna ruin my career. I'm gonna lose my license to practice medicine." And we thought, how could that be possible in this day and age? Unfortunately, that fear of basically her career being over was one of the things that we believe contributed to her decision to take her own life. And that's when Jennifer and I decided, in a moment of calm, that we needed to tell her story. What we know is that the pandemic has had a significant impact on the mental health of the workforce, which goes beyond just burnout. It goes to things like PTSD and depression, and ultimately potentially suicide. The giving culture plus the competitive nature and how many hours they spend doesn't lend itself to self-care, and that takes a toll, and that needs to change. This country has had rules in place for years and laws in place for years to take care of the workforce. In healthcare, it's a little different story. So we need to elevate that focus so that there's a clear recognition and connection between creating an environment where the worker can thrive and then do their best work and take care of patients.
So in my remaining time, I'm going to walk you through a few slides about the impact that we've had and our areas of focus. When we go to the next slide, what you'll see is that in response to that healthcare industry and healthcare community response, we have really focused our efforts on three major areas. And for some reason, Vito, the slides aren't showing, at least on my screen right now. Those areas are awareness, advancing solutions, and advocacy. And I'm going to walk you through each one of those. So from an awareness perspective on the next slide, what you'll see is that this story has appeared in over 400 national news publications. We've co-authored 11 national publications as well, including one a year ago, February, on suicide prevention. We've done now over 100 panels and keynote speeches, done a series of podcasts, and certainly tried to make a name for ourselves in social media, although my adolescent children don't think 7,000 is much of a social media following. But the important message here is actually on the next slide, is in response to all of that. If you just go to the next slide for us, what you'll see is we've heard from the healthcare workforce that her story has resonated with them, so much so that that these individuals who've reached out, and I'm sure many others who haven't, have done something different. They have taken care of their well-being because they've seen themselves, they've seen her and her story in themselves or their residents or their colleagues. Or interestingly, we've heard from those in the mental health community taking care of the healthcare workforce that the important details of sharing her concerns around stigma in particular, her concerns around licensure. And in the case that you'll see a quotation on the bottom of the page, what you'll see is that was from a therapist whose patient had expressed concerns about her mental health. Her reputation, and this patient was then safe because the caregiver was able to recognize the parallels in the story. So if you go to the next slide, what you'll then see is this national initiative, which is our work to advance solutions. We've called it All In Wellbeing First for Healthcare, and you'll see across healthcare approach here with the American Medical Association, the American Nurses Foundation, the National Black Nurses Foundation, Medicine for, the American Medical Association, the list goes on. And what we've been focusing on there, if you'll go to the next slide, are really two primary goals. One is to advance solutions, which we know exist but haven't scaled yet, to improve the well-being of the healthcare workforce. And let me be clear here, a lot of these solutions are about systems change, not necessarily about making the workforce more resilient. We've heard from the workforce and they've said that that they need to be in an environment where they can thrive. And so that's the primary focus of that first goal. And then the second is to eliminate the mental health and well-being challenges that disadvantage our healthcare workers. Read into that. Credentialing questions and other kind of licensure questions, which really act as inhibitors to the healthcare workforce getting, and physicians in particular, getting the help they need. On the next slide, what you'll see is the advocacy impact, and there's no better impact than having a new federal law, first of its kind federal law, named after your sister-in-law, Lorna. This law was passed unanimously in the Senate and by a very strong majority in the House. It was then signed into law. You'll see that in just a second. But before we go there, let me tell you a little bit about the law, because it is a first step in a body of more law to come. This establishes grants to support the well-being of the future healthcare workforce, those trainees. It establishes well-being grants for the current workforce as well. It also has a national evidence-based education and awareness campaign targeted at advancing solutions at the systems level and supports at the individual level. And then finally, a comprehensive study of these issues. $140 million in new programs, $103 million of which has been allocated already by HRSA. They allocated those dollars on the 20th of January. That actually preceded this next slide, where you'll see us in the White House on March 18th, signing this first of its kind law into place. I will tell you all, we're already working on version 2.0, because if we go to the next slide, what you'll see is the reactions to the law have really fallen into two, maybe three buckets. The first is you've helped us change healthcare delivery and healthcare systems forever. The second is there's a lot more to do, and we were very aware of that. This was step one on this staircase of law that we hope to create in policy to support you and your colleagues. And so these issues around licensure are concerning, and so they become our next area of focus. So if you go to the next slide, what you'll see here is you'll see that these invasive licensure questions are acting as an inhibitor to the workforce. I got a chance to testify in front of Congress and told them that given the trauma and burnout that the healthcare workforce has experienced, this is like sending the entire healthcare workforce off to war for 18 months and then refusing to support them when they return. And what you'll see from a data perspective on the next slide is that the data that came out just the day after these Lorna Breen Act grants were given out, so January 21st, show that the number one barrier for physicians that they identify to getting help for burnout or depression is risk of disclosure to a medical board. Also just followed closely behind by concerned about being on insurance records. So these are barriers we know exist. And so if we go to the next slide, what we can see there is there are really there are probably 7, there are probably 20 of these barriers, but structural barriers that exist. In September, I published an article, one of the 11 we've published, and the first 4 of the 6 are bolded intentionally because these are questions that appear in licensure. And I'd edit this to say not just state licensure, but specialty board licensure, hospital credentialing applications, insurance applications, malpractice applications, and the list goes on and on. And so what we've done is because we know these are real issues as demonstrated by that data that came out on the 21st of January, we got to knock each one of these down. And so if you go to the next slide, I just want to end by saying thank you and inviting you all to join us in this conversation. We have helped to cascade one ripple, one pebble with Lorna's passing, and tried to make it into a tsunami, if you will, of change. But we need everyone in this with us, and we would invite you all to join us. You can find out more about us or email me directly on the email below or on the information below. So thank you for having me, and I look forward to the Q&A session.
Thank you very much. And yes, it's so unfortunate again that this pandemic has brought out the worst in the mental health of our healthcare workforce. But congratulations on being able to do such a wonderful feat for our healthcare workers to get this law passed. And I know HRSA does a great job with their Bureau of Health Workforce to train, like you said, the next generation, so that hopefully we'll have less problems in the future. And NHMA has been a supporter of the law and the legislative efforts, and will continue to support it. So thank you very much for being here. Again, I'm just going to remind everyone, if you have questions, to please put your questions in the Q&A box, and we will have a discussion at the end of this session. Our next presenter is Dr. Charles Jin. He is the medical director for Centene Advanced Behavioral Health, and he is a distinguished fellow of the American Psychiatric Association. We'll talk about the impact of COVID on mental health for the Hispanic community and its healthcare workers. Dr. Jin.
Thank you. Thank you, Dr. Rios, for having me and give me this opportunity to really raise the awareness of mental health issue in our own community, meaning healthcare worker. And next slide, please. Now, this why it's important. Optimistically, we could say that the pandemic is about the behind our rear mirror, and but we always needed to be prepared. If you look, the pandemic to this scale or similar scale, it could happen, and it's not whether it could happen, it's actually when our next pandemic will come, as many experts has predicted. So we need to be better prepared, and not only for our healthcare work in our community. How we learn from our experiences. So let's look at what we did this time and what we learned from our own experiences. Next slides, please. And now this slide is a long worthy of what means a burnout in a psychological term. But in short, is basically you no longer feeling passionate about what are you doing, and you feel frustrated, and the place you work found you being ineffective, and so on. So and then you feel exhausted. This is feeling. So if you find yourself exhausted and no longer feeling passionate about your work, feeling incapable of doing work, that's a very good sign. It's a red flag for the burnout. Next slide, please. Next slides, please. Yes. Now, sometimes the burnout in health work, it can actually measurable. The burnout term is actually used very successfully in cross-industrial, not only with the healthcare worker, it's used in other industry. The burnout is scaled in 1 to 7, and each point you will have a decrease about 30% of your efficiency from the point starting point. And the measurement of the burnout many times is like what we lost, doctors and nurses to suicide and so on. Those are immeasurable losses, not only to the community, but to the family. Those is just really painful. But a loss a single physician in terms of dollar term, it's probably up around $500,000 to about $1 million to replace another doctor, training and so on. This is the data on this during the pandemic. This is about a year into pandemic, between January 2020 to May 2021. The pandemic caused about 3.5 million COVID-related deaths, and about 80,000 to about 180,000 are considered as a healthcare worker. And now I did not have a searcher, but I couldn't find the directed data on the Hispanic healthcare worker in terms of direct data, but we do have some indirect data. Next slides, please. And there's a couple of very good literature review, and one of it is that I included here is the surveyed, survey that it's a meta-analysis on the depression, anxiety, insomnia, and across about 10 very good quality of study. So here is a kind of summary. So majority of the healthcare workers during the pandemic actually reported a mental health issue, about 90%, overwhelming majority. And you see there's quite a significant discrepancy between the reporting rate. 81% of nurses reported, but only about 19% of physicians made it reported. I will really look at this as a reporting bias rather than truly reflecting the actual burnout. Next slides, please. And this is one of a very large scale of a survey done by Mental Health American, one of the old, large mental health advocate group. They found a very high number of stress level in the healthcare work during the pandemic. Again, it's stunning. 93% of healthcare workers reported the stress and stretch out anxiety very high. Again, frustration. They use a more a general term to get a survey, which is actually, I think it's right. If you're using a more technical term, then you may not getting a accurate report, because each person's interpretation may be very different. So I think this is actually a very good approach. And you, I'm not going through every one of them, but if you look at those, are very high percentage of stress level during the pandemic. Next slides, please. Now, if you look at this is another very good meta-analysis. It also shows this is a more using a diagnostic term, anxiety, depression, and sleeping disorder. Again, you see the number goes down a little bit because it's actually, they have a more criteria to meet, what is anxiety, what is depression. So you still find it close to about a quarter of people reported anxiety and depression, and the sleeping problem is close to half of them. And and we know all those things actually can lead to more other psychiatric illness, including increased odds of you running into addiction, alcohol consumption, and so on. Next slide, please. And this is a slide that probably many people already see it. It's reflecting the ratio proportion of the American healthcare working force, and you see there's a larger portion of a Hispanic healthcare worker is in the direct patient contact healthcare worker working force. Next slide, please. Now, I'm actually a pediatric psychiatrist, so I want to share this. This is actually, when I found this, I found that this is a very, very interesting. It gave me a hope in this really depressing period. If you look at it, we have a Surgeon General come out to tell the nation that the American children due to the pandemic, they're suffering from anxiety, depression, suicidal rate. Every category is increasing, and he used the term of a crisis to describe this. But I want to give you a hope and what we can do as individual physician and healthcare worker to make a difference in our community. So this is this is the national data, which shows it's a very smart design in the data. This data is already going on by the CDC study, so it's already there. But they extrapolated during the pandemic period, and they see what is increased during the pandemic. It's in every category. You see the kids are doing much worse during the pandemic. Next slide, please. And now I want to give you, this is actually the two study I really like. It's represented a light of hope. This is studied in an urban community, although they didn't disclose the exact community, but from the researchers, the association and so on, I'm pretty sure this is a Houston area community. So they have about 300 adolescents participated in the study. It was a large study, was already going on, and then they took advantage and then made a comparison during the pandemic. And this is a large Hispanic community. It's a 72% considered as a Hispanic community. Now, if you look, this is not a wealthy community. Majority of them living in a apartment complex, and their median income is about $20,000 less than the city average. Next slide, please. And now, what they found, actually, they found the youth who had experienced elevated the mental health problem before the pandemic, the symptom actually significantly reduced across all the domains during the pandemic. Their internalization and externalization problem, those are ADHD and anxiety, depression symptom, we characterize it in a larger category. In the total behavior problem, they all reduce, and it's statistically significant. And what did they found? The research actually puzzled. They said, what's going on with our study, and how do we interpret this data? And they found that it's actually due to the family involved. The parents get more time to spend time with their children, and the community, this is actually a very unique community. I want to show you in the next slide. Next slide, please. Now, if you look, this is a very unique community. This is a kind of a unique community in the sense it has resources that are not that are shared by the majority of Hispanic community. They have a very large the NGO in the community that was open and functioning during the entire pandemic. And they made all the children who go to online have access of internet. If they don't, they give them a hotspot so that they can have access to internet. And they also provided support for all the clinic and the community healthcare was functioning through entire pandemic. And they also said that there's a limitation in the study because the pandemic will actually worsen after that, and how long the family can sustain that kind of stress, that's another question, but that's required further research. Next slide, please. And now this is another study that is done in I think it's in Colorado. That's a Lulu Hispanic community. It's not an entire Hispanic community, but it's a pretty large proportion of the Latinx community. It's 45%. And interestingly, they also found during those period of time, the kids did better than the pre-pandemic level. And again, there's a uniqueness in this community, which is shared by the study that the first one did. Next slides, please. And so they basically found that during the pandemic, for the Latinx family and the non-Latinx family, and they compared the two communities, and they found that there's no significant difference in terms of how they are handling stress and so on. And they made the same conclusion for their finding is the family structure of those families that made a difference and made a positive impact for those kids involved in the study. Next slides, please. And all right, so as an individual physician, I think that's a very important take-home lesson to learn. A strong community equals to a much healthy use. And there's things that we could do as each individual physician. Next slides, please. Now, how are we taking care of ourselves? You are a important assets for your community. This is, I think, goes well to how to taking care of ourselves is recognizing the sign of burnout. I listed all those important signs and acknowledge that your stress is a very, very important first step to recognize your own mental health care needs. Next slides. And I offer some tips to increase resilience from yourself. Take a break. Those are not rocket science, but if you do that, it definitely can make a difference. Have adequate sleep, eat your meal, have a healthy meal, take a break, and exercise, and also share your stress and talk about your work with your family and a coworker. Those all can make a difference in your ability to handle the stress. I think that's all I actually needed to say in this. Yes.
Thank you, Dr. Jen. Next, we're honored to have Dr. Moira Szilagyi, who is the president of the American Academy of Pediatrics, talk to us about mental health in children.
Hi, everyone. Just trying to share my slides. Hopefully, I have to move something out of my way. And hope you can see them. We all set?
Yep, you're good to go.
Okay, thank you. And I certainly want to thank the organizers for the kind invitation to be here today, and my two fellow presenters for their amazing talks from different viewpoints about how big the mental health crisis is in the United States. And so I think we are all ready to move on from COVID-19, but as our CEO keeps saying, the pandemic isn't quite done with us yet. And a lot of children, as has already been pointed out, have experienced really life-altering disruptions in daily routines and born periods of really extended isolation. And many, and I think particularly among populations of color and in our Hispanic population, live with caregivers, as has already been pointed out also who worked on the front lines of service, cared for multiple generations at home, and were at greater risk of illness and stress by changes in employment and income. Over 200,000 children in the United States have lost a primary or a secondary caregiver, and most of those are children of color. And it's becoming clear that we're really going to be dealing with this now for quite some time. And we're really right to be concerned because research is telling us that the seeds of lifelong health, mental health, and social well-being are planted in childhood. Even before the pandemic, as was noted, there were already troubling increases in pediatric mental health and substance use disorders, and in self-harm and suicide. There's literally, I think, a crisis of hopelessness among some of our youth, and it was really reflected in suicide rates that rose for the decade preceding the pandemic, with significant disparities by race, ethnicity, gender, and sexual identity. And in 2018, suicide became the second leading cause of death among youth 10 to 24 years of age, accounting for more pediatric deaths than the other 20 leading medical causes combined. The highest rates were among American Indian and Alaska Native youth, but rates among Black adolescents were actually rising the most rapidly over that decade. And during the pandemic, data shows that overall rates of depression, anxiety, and suicidality climbed further, although I was very happy to see Dr. Jin's more positive data in specific communities. Many people also got to see what pediatricians already know, that the poor, people of color, and other marginalized populations have less opportunity, less access to quality education, healthy nutrition, decent housing, employment, healthcare, and technology, live in more violent neighborhoods that often have more environmental hazards. And we came to realize that the historical embedding of racism into systems and structures ensure that Black, Native American, Alaska Native, Hispanic, and some immigrant populations have less opportunity. Latinos have faced disproportionate health and economic impacts. In the early months of the pandemic, the Hispanic population was more likely to contract COVID-19 than non-Hispanic white counterparts, and much more likely to be hospitalized and die, as Dr. Rios pointed out. Latino workers are overrepresented in industries that have been hardest hit by the pandemic, facing large losses in employment, particularly among Hispanic women in the service industries. And according to a CDC Adolescent Behaviors and Experiences survey conducted between January and June of last year, Hispanic youth have been particularly hard hit. 37% reported poor mental health, 46% reported persistent feelings of sadness or hopelessness, 20% that they seriously considered attempting suicide, and 8% reported that they attempted suicide. While 42% of Hispanic youth felt close to people at school and 67% virtually connected with others during the pandemic, these rates were lower than for peers from other subpopulations. And the AAP and the American Academy of Child and Adolescent Psychiatry and the Children's Hospital Association became so concerned about the overall mental health status of America's young that we declared a national emergency in child and adolescent mental health in November of 2021. So I want to take us on a little walk through why stress is so bad for children. And I agree with Dr. Jin that the more family-oriented cultures, such as the Hispanic culture, your children are a lot better off than children from my white culture, which is much more individualistic, because it really does buffer children better. So many of you are probably familiar with the concept of toxic stress, which tells us that while a little bit of stress is good for children because it promotes learning, and more serious stress is still tolerable when children have buffering relationships to rely on. Significant stress that occurs in the absence or dearth of buffering can lead to prolonged activation and eventually dysregulation of the child's neurohormonal stress responses. And this essentially enables trauma to become biologically embedded through several changes. Telomeres are shortened, which can shorten life. Epigenetic changes or changes in gene expression. Alterations in our immune system that suppress our ability to fight off infection while sowing the seeds of inflammatory disease. And changes in brain architecture and function that occur from epigenetic changes and stress hormones. Back in 1998, this landmark study called the Adverse Childhood Experiences Study was published. And it was done on adults. And it showed that even in a low risk, predominantly white, college-educated adult population, that poor mental health, and social outcomes were actually dependent on the dose of adversities in childhood. And in particular, these adversities, which are intrafamilial, they occur in the familial. So what it really basically said is that the greater the stress burden in childhood, worse adult outcomes are. And these studies have since been replicated across cultures and countries. So in medical school, most of us learned that when the brain perceives stress or danger, the HPA axis activates the stress response that involves the release of sympathetic hormones and cortisol. And it's usually shut down when the threat subsides or help arrives because of built-in feedback loops. The problem happens when the stresses are frequent, severe, or unrelenting, and there's no safe, stable, nurturing caregiver to buffer the stress. And it turns out that some other stressors have the same profound effects on life course outcomes as those 10 original ACEs. Racism and felt discrimination, living in deep poverty, being bullied frequently, living with high levels of community violence, forced or unexpected separation from a parent, and having a history of foster care. As you all know, families are usually a child's safe harbor in the face of stress and adversity. Parents typically shield their children from adversity and they prepare them to cope with it. But sometimes stresses like poverty, racism, financial insecurity, and social isolation, among others, can overwhelm a parent's coping and buffering and also a child's. The pandemic was for many of our families a perfect storm of such adversities. For many families where the pandemic stresses were layered onto multiple existing challenges. Yet there's something we can do to help children, and it's rooted in biology, and that something is called trauma-informed care. And it's important because trauma and ACEs are so prevalent, and we know the harm they can do across the childhood and the lifespan. Trauma-informed care is evidence-based and is derived from sciences just beyond pediatrics, but they inform our care. The sciences of attachment, parenting, resilience, evidence-based mental health care, brain development, and epigenetics. They literally teach us what we need to know to promote healthy mental and emotional development. Trauma-informed care is a transformational approach in pediatric care. It is care in which we all assess, recognize, and respond to the effect of trauma experiences on children and their caregivers. But it also recognizes that we too, as healthcare workers, may carry trauma with us or experience secondary traumatic stress from watching the suffering of children, or suffer the moral injury that leads to burnout in systems that are driven by efficiency and finances rather than by a commitment to caring and patient needs. It changes the question in medicine from what's wrong with you so I can fix you, to what has happened to you and what is strong with you, so I can understand you and help you heal. Since pediatrics is a preventive specialty, I broaden this definition to include the promotion of resilience to prevent trauma or its effects and to promote healthy brain and emotional development. Trauma-informed care takes advantage of a fourth biological response to threat, the affiliate response, which depends on being in relationship with others. We already harness this response every day in our own relationships and in our work with children and families. It turns out that the first thing that happens when we face with threat is that oxytocin is released by the posterior pituitary. And if a child or an adult looks around and finds a supportive caregiver or social network, the stress response is blunted or turned down. So buffering relationships reduce the stress responses, and over time in children, they embed resilience. Renowned developmental psychologist Ann Maston calls resilience promotion ordinary magic, because research has shown that resilience basically develops in the give and take of safe, stable, nurturing caregivers in a child's life. And in the growth that occurs through play, exploration, and exposure to a variety of typical activities and resources. Of course, many of our children don't have this access either. More recent research really shows how resilience is rooted in biology. It turns out that when we become parents, the brain is flooded by oxytocin, activating the brain's affiliate network, which extends from the back of our brain and our limbic system through our midbrain and dopamine reward system to the prefrontal cortex up front. This leads a parent to orient toward the newborn and engage in typical human and culture-specific caregiving, which leads in turn to the attunement of parent and child we call biobehavioral synchrony. Unbuffered adversity and substance use can impact the development and the function of some of these affiliate network structures, essentially hijacking them, making it important for us as pediatricians and as physicians in general to know about childhood adversity and trauma, and even parental adversity and trauma, because that can affect caregiving. Once we identify trauma or risks, there's actually a response we can make in our pediatric settings. I often begin with asking about a parent's upbringing, so I understand what they bring to parenting. But we all need to respond to trauma with empathy, validate a family's concerns, and normalize the child's response to what was an abnormal happening. This applies to burnout also. We teach pediatricians how to talk with families about trauma and its impacts on the child. And we tell them about trauma-informed anticipatory guidance. And I can't express the importance of follow-up and care coordination. The AAP is developing a focused multi-year mental health strategy, which will be underpinned by relational care or trauma-informed care. We are developing a rapid response to address suicidality, training and education for pediatricians in relational care and mental health, and long-term transformation of our pediatric health systems to support and sustain this model, which is going to need a lot of policy and funding changes. And we've partnered with the American Foundation of Suicide Prevention and the National Institute of Mental Health to develop a blueprint to prevent youth suicide. So we're bolstering youth suicide and prevention nationally, helping to train pediatricians and others to identify and support youth, and to address those upstream factors that cause and intensify disparities in risk. And we have already partnered with the Children's Hospital Association around a mental health crisis awareness campaign to increase integrated care and primary care and the size of our pediatric mental health workforce. So though the pediatric mental health crisis is dire, the great news is we actually know what works. The sciences of resilience, parenting, attachment have shown us that childhood trauma and adversity do not have to be destiny. And I really feel that through our leadership, our roles as clinicians, educators, researchers, and advocates, we can actually create a world and a future in which all children can achieve optimal health. So I'm going to stop sharing. Hope that worked.
Okay, well, thank you. A lot of great ideas, a lot of great strategies from all three of our speakers. And again, I just want to remind the audience, if you can give us your questions by typing into the Q&A box at the bottom of your screen. We do have some questions here. We will be on the screen here till 15 minutes past the hour. So I'm just going to go ahead and start with the Lorna Breen Foundation. I think it's great to see the advocacy that you have built up. And if you could tell us a little bit more about the strategy you used for advocacy to get to an actual law overnight in this Congress. I think that speaks to the immense opportunity we have to change our healthcare system to include more mental health. I'll just say mental health strategies in a positive way. But could you just tell us a little about that story? I think that's something.
Sure.
We
And I think it's really important what you said. I mean, so we had the benefit in Virginia, which is where we're located, of having a United States senator who reached out to us directly after hearing about Dr. Breen's story. And so he initially reached out just to express his condolences, and then he asked us how he might help. I don't think when he asked that question, he realized I had been in healthcare over 20 years and I had a few ideas. And so he got a very detailed bulleted email, and that started the conversation. And so we took a story and we moved from awareness to action. And what we did there was absolutely focusing on making this a bipartisan issue out of the gate, very intentionally so. And since I've had a whole career in healthcare, I also know how siloed the industry can be. So we were very intentional about bringing together over 70 national organizations, including this organization, to endorse the bill. We also we made a very early strategic move, which was not to bite off too much here. That we knew this would be, if we could get our nose under the tent and start somewhere, that we could then build upon it. And so when you look at the law, and it's creating programs to support the well-being of the workforce and raising awareness and having a study component, you might at first blush say, well, what'd you really do? Well, we've started this conversation. We've created a roadmap for the future, and we have alerted policymakers on both sides of the aisle in both the Senate and the House of the need right now. And we've done that through storytelling. We've done that through bipartisan work. And so that's been the secret sauce. And I'll tell you, to the, I think in some ways, dismay of the paid lobbyists in Washington, D.C., we haven't had to use one. And so a lot of this has been really being visible, telling the story, really elevating the physicians and the nurses who come to us and sharing their stories, because, our family wasn't going to benefit from, or our foundation wasn't going to benefit from this law. This law and the name and everything was inspired by, in our actions, were inspired by the response of the workforce. So we just kept giving them data, and it worked out. We had a very supportive, we passed the Senate. We actually ended up having to pass the Senate twice, and both times we did it unanimously. And so it really speaks to the need of our healthcare workforce, and the fact that we needed to get a start on a body of law that hasn't existed. So that was I'm not sure that was the recipe book that you were really looking for, but that was where we did.
Well, it is an incredible story, and congratulations again for that and all the work that you're doing to raise not only awareness, but like you said, action, advocacy, and now we have an act that translated into many, many dollars to training institutions for the future health workforce, so that we can help, train the next generation.
And if I could just add one thing, we're already working on version 2.0 because we know there's more to be done. And so that's exactly what we had hoped, and we're already getting calls. What do we do next? I mean, we got calls from the White House just month ago. What do we need to do? What do we need to do? So
Yeah.
I think there is a desire to help right now. And so we're trying to build a coalition to continue to do that.
Well, we certainly want to continue to work with you. And let me just ask Dr. Jen to comment on his company, Centene, who's did this wonderful study about rural and urban families and the importance that you found. How did that study, those studies translate into action for you at Centene? And how can Centene become a leader? We also work with Centene because it is a major Medicaid insurance company in this country, and we know how important it is to take care of the poor. What do you see as the next step for the success story at Centene for mental health?
Yes, yes. Well, Centene certainly has a very much focus on to reach underserved community. But I want to just clarify, those two studies are not funded by Centene. They are independent study. They're conducted by the academic community. During the pandemic, Centene actually, the internal data, which I presented in the annual conference meeting for this organization, we see a very similar trend during the pandemic that we see the emergency room visit dropped, the healthcare, routine healthcare dropped, and however, is a very important data that we also found is that, which is consistent with other people's data, is the emergency room visit that related to suicide that actually jumped to about 50% during the pandemic. So the pandemic does have a very much impact to the mental health well-being in the Hispanic community as well. The Centene has increased a lot of outreach efforts during the pandemic to enroll the Hispanic community for Medicaid and Medicare service. I think it is a very convincing upper trend of the enrollment efforts that Centene did. And the Centene is also, that I'm also a part of it, we have submitted a R1 grant to the, for study the treatment of the depression that impacts on the overall health, physical health as well. So those are a lot of the Centene efforts that is actually focused on the mental health care as well. Centene is a very much aware about social determinants of the health, and there's a large efforts. We are trying to look at the internal data to see whether providing enhance the resources that are available to the community and their impact on the mental health. If you look at it, sometimes people said, the founding a nonprofit organization such as Big Brother, Big Sisters group, what are the impact you have? It's those data is really shows those NGOs efforts made a significant difference in supporting those, the community that are involved in those two studies. The money, to me, are well spent and have a most impact on in the community, a positive impact in the community. I think that's one thing that if we could, we should continue pushing forward for where the funding should go, where the money should go is the community, and where the need and you can actually make a difference when those dollars are given to the community and give the resources to the community.
Thank you. And Dr. Szilagyi, you mentioned the importance of the American Academy of Pediatrics and guidelines, et cetera, for children's health. In terms of mental health, what do you see as the future? Where are we headed for the training, for example, that could be done in maybe not just medical schools. I'm going to talk about interprofessional training of mental health for children, for nurses, for doctors, for dentists, all of our, not just the psychiatrists, but all of our healthcare workforce needs to understand those strategies that you discussed very, appropriately.
Well, I know I'm biased, but I think that the trauma-informed care approach, which is an unfortunate name because it's really resilience-enhancing relational care, right? It's the type of healthcare that we probably all want to receive from, whether we're adult or child, from whoever we're seeing, a person that it's a personal relationship in which healing can occur, because that's actually the foundation of healing in medicine, right? It's a relationship with the people who are caring for you. So your question, I think what we see the future is, what we hope the future is that we are going to have an increased emphasis on mental health, certainly in training physicians all the way through medical school and residency training. Right now, pediatric trainees are really only required to have about 4 weeks of developmental and behavioral health training, which is completely inadequate when one considers 30 to 40% of our visits are related to child emotional and behavioral issues. So that's a big issue. We are actually having conversations with our partners in the American Academy of Child and Adolescent Psychiatry around how we're going to do this work more collaboratively. And we have reached out to family medicine, nurse practitioners, and other organizations too, because this really is going to have to be a joint approach. I will say that I also believe that we really need to change our systems of care. Trauma-informed care at the front and can't be done in a system that doesn't support that type of care. And so there's some literature on trauma-informed care systems and what they might look like. They would certainly align their financing with this type of care, probably less emphasis on how many patients you're seeing them than on the quality of the care that you're providing for them and whether it is relational care. I think it's also important because in a trauma-informed care system, that's a team-based approach to care, where people at the front line of the care system and the families who are served by the care system also have a formal relationship with the leadership on an advisory board, so that there is feedback that's going on. It's where there's an approach to supervision, where supervisors use a more reflective form of supervision than kind of this top-down approach, where everybody has education and training. I could go on. It's a long list, but I'll stop there.
Okay, there's a couple of questions in the Q&A and chat about Latino health, and I'd be happy to just answer. One question is about our organization, National Hispanic Medical Association, and what we have done in terms of burnout of our own physicians, Latino physicians, and as was pointed out earlier, we're only 5% of all the doctors in the country, even though the population is growing to be 1 out of 4 Americans will be of Hispanic background by the year 2035. So our needs for mental health are immense too, because we end up being, the catch-all wherever we work, because there's so many Spanish-speaking patients that end up going to the Spanish-speaking doctors, whether they're in academics or they're in private practice or in our clinics. The community health centers around the country, a lot of Hispanic patients and Hispanic doctors are needed there too. I think what we've done really is focused on mental health burnout for the last several years. Before the pandemic, we were already seeing the trends of the burden on our doctors because they're overburdened, doing different jobs, including translation. And I think that the speakers at our conferences on mental health burnout have been really great. And I think what I can do is put together a list of some of the speeches over the last few years and connect them to this webinar on our website, which will be at nhmamd.org. We also started this year for the first time councils by specialty, and we certainly need a council of psychiatry, doctors being psychiatrists. We have councils for the primary care, pediatrics, internal medicine, family medicine, but they're just starting, and we're very interested in helping young medical students consider going into different specialties by actually meeting residents and faculty by specialty, so that they can help each other with mentoring and helping out and building our family of doctors, which is what our National Hispanic Medical Association is for the Hispanic doctors around the country. The other thing I'll just say is that we're going to focus on mental health much more, because we see how important it is for doctors to know how to take care of their families and children, especially as we've just learned. The other question I want to ask Dr. Jen, if you can talk about this, since you mentioned the rural versus urban, what do you see as the differences in our minority of poor people that live in rural versus urban in terms of the mental health needs?
Yes, both communities share a very similar challenge. There's a high mental health care needs, but with a large service gap. And especially in the rural community, but urban community is not doing much better either in that sense. It's a national-wide problem. You see, Hispanic community, they have a high level of mental health care needs in terms of depression, anxiety. All the percentage incident is higher than the other community needs, but the service care needs is not matching that at all, and it's a lagging behind than the other community. So I think there's a long way road, the journey that we needed to walk to reach that goal, to provide adequate. We're not talking by it's adequate care to meet that mental health care needs for both communities.
Yeah, that may be something for the Lorna Breen Foundation to consider. We have in HRSA, where the funding went to train medical education or health education, also has a major focus on rural health and the rural hospitals, as well as the migrant clinics and the rural clinics are all funded by HRSA, and they could use funding for grants for mental health services, maybe not the training so much of medical students, but the in-service training of the doctors and nurses within these places that often get overlooked. And really, it's so important to the country to have our farm workers and our rural workers, whatever they do in the rural communities, to have access to mental health services in their communities too. There's also the National Health Service Corps, which has been great in putting doctors and nurses and other health workers in different places that are considered underserved, health professional underserved, and it would be great to make sure that mental health is part of that definition, and that we somehow, incentivize the system to have more focus on mental health career development, not just at the doctor level. That's the part of the problem, is that it takes so long to get doctors trained. I know our public health departments have family therapists, counselors, who are social workers. And that might be another consideration to consider more about how to go through the Department of Education. The Department of Education funds careers in K through 12 and higher education. That's not the biomedical healthcare workforce. And we need a lot more people at all levels to help with mental health of our communities. I don't see any other questions, but I just asked the audience, the panelists, if you'd like to leave us with one thought, I'd be happy to. Dr. Jen, do you want to just one last comment?
Yeah, I want to leave this, just like what I said in my slides um, there's things we can do as each individual physician. If you are helping a family who come to see you, and if you help to, give the tool to the parents and how to help their children, you are doing a very good service to them. Educating, the time you're spending with your children, they are valuable. They are making your children healthy, not physically, but as well as their mental health. So you can make impact and keep doing that, and you will feel good about what you're doing for your community and yourself as well.
Yeah, okay. Corey, one last comment?
I will. I'll echo that and take it a little different angle. It's amazing the impact that one or a few individuals can actually have on an issue, and particularly the local culture. And so, while we may be in a time where there has been maybe more helplessness than hope, but I hope that's changing. Remember the power that each one of you has to actually make a change and start to model that behavior change, because we know that a lot of this work, this is a multi-layered onion here to achieve, but one of the things that each one of us has control over is to how we behave and how we are going to either take care of ourselves and each other. Checking on yourself, checking on each other, recognize there's a connection between your well-being and the well-being of your patients. And thanks again for having me.
Sure. And Dr. Salachi from the American Academy of Pediatrics.
Yes, so I think that both of my colleagues here said that very well, that I think we all have a really crucial role to play in the care of children, whether we do that in our clinical care or through our advocacy work or in some other way, and that being truly present in the moment with them, listening to them, healing begins in a relationship. So thank you so much.
Okay, well, thank you. And from the National Hispanic Medical Association, I want to thank our staff, Vincent and Michael, for helping us. Let's see, I have please remember to complete our post-webinar survey that will be emailed, or there's actually a Q code here, and we'll have a raffle for a $25 Amazon e-gift card. And I do want to just say that we are having all of these slides and this presentation available on our website in a week, nhmamd.org, and also on our YouTube channel of the National Hispanic Medical Association. So for everyone, thank you very much for attending, and thank you for having us present more information about COVID-19 and the impact on our communities. And we will be having another session in 2 months. We changed it to every other month this year, but we're very happy to have you attend. Thank you very much. Good night.
Thank you.
All right, thank you.
Good night. Thank you so much.